It's rare that it works, I think. So what happens if they don't have an A wave or if they have MS? There are still some values that we can use to assess diastolic function in patients that have sinus tachycardia, or AFib, mitral valve disease, hypertrophic cardiomyopathy. So with sinus tachycardia, we're going to see fusion of the E and A waves. There's an increased A wave velocity. The E to E prime retains its ability to predict LV filling pressures. Patients with atrial fibrillation, which most of us see all the time, probably a third of our patients have AFib. We know that there's no A wave. There's going to be beat-to-beat variability. You can still use the D cell time. It correlates moderately with filling pressures. Anything greater than less than 150 milliseconds indicates elevated filling pressures, but it also indicates a poor prognosis for that patient. You can use the E to E prime ratio. It does retain its value in patients with AFib. A ratio of greater than 11 indicates it corresponds with an LVEDP of greater than 15. Patients with mitral valve disease, mitral stenosis has its limited Doppler value. The E to E prime is not useful. This is where the IVRT measurement can come in and help us out. So the shortening of the IVRT and the increased mitral E wave velocity does correspond to a mean left atrial pressure. Ratio of less than 2 suggests elevated left atrial pressures. Patients with mitral regurgitation, there's increased compliance of the LA and the LV. There's a high E wave velocity, so a high LA LV gradient early diastole. The E to E prime is useful in patients with depressed EF, but we can also use the IVRT here. So the ratio of the IVRT is the time difference between the mitral valve peak velocity and the annular E prime is useful with these patients. So hypertrophic cardiomyopathies presents us with a few different problems. We can't use the E to A, we can't use the E to E prime, we can't use the mitral D cell time. So this is where you can use your A wave duration from both the pulmonary vein and the mitral inflow. So the time difference between the mitral A wave duration and the pulmonary venous A wave duration correlates best with filling pressure. You can also use the pulmonary artery pressure. You can use the left atrial volumes, but this is very difficult to assess. So prognosis for these patients. It's because they're so preload dependent, it's the volume dependent, it's critical to manage their preload. The morbidity rate is nearly the same for patients with systolic heart failure. The mortality rate is not as high, especially if they've been diagnosed with grade 3 and grade 4 diastolic dysfunction. They have a high rate of death, almost as high as those with classic systolic heart failure. So how do we make our exams better? By practicing on everyone. Doing a high quality diastolic exam is not only feasible, but it's essential to our success. Because the reading cardiologist is only going to get what we give them, we need to use all the tools that we have to be able to help them in the diagnosis of the patient.